Welcome to the Four Eyes podcast, brought to you by Young OD Connect. We give you a clear view into the new grad optometry world across Canada and the US. We are your hosts. I'm Dr. Deepan Kaur.
And I'm Dr. Amrit Bilku.
Hi, Diana.
Hey.
Nice to see you again.
Oh, I like your glasses.
Thank you. Okay, good. If another OD is liking like the glasses that I picked, then it was a good decision.
Then you did a good job.
Yeah.
So, Diana, thank you so much for coming on the Four Eyes podcast. We're really excited to hear about your journey and your healing through your concussion. But before you dive into that, can you just tell the listeners a little bit more about yourself?
Yeah, absolutely. My name is Diana Chu, and I'm an optometrist in the Washington, D.C. area. I practice in a high volume surgical medical practice, and it's been kind of an interesting experience to receive a lot of primary and secondary referrals and then kind of go through an experience that a lot of my patients are telling me about. And so that's kind of what we'll probably talk about today is our concussion and TBI experiences that I do see quite a bit of in the medical optometry space. But yeah, that's sort of what I do on a day-to-day.
If we can just get into the details of your experience of what happened and what led to your concussion, like what occurred.
It's in some ways you have like these experiences in life that are kind of perspective shifting, and you're just really, you look back on it and you're really thankful to be able to say like, I'm so glad I kind of came out through that on the other side, and this is like what I've learned. And so in my experience, I was like in a terrible motor vehicle accident through no fault of my own, and then from like the head trauma, I suffered a concussion and whiplash in addition to like some other injuries that like thankfully I've recovered from, but certainly was more extensive in that recovery period besides just lying in bed and resting at home or something. And so today, yeah, like I can hone in on that concussion recovery and the whiplash like associated with that, and how we can better looking for better ways to kind of help our patients. And I hope that this conversation helps like all healthcare providers and addressing patient needs that for those suffering with TBIs and traumatic brain injuries.
Yeah. We're going to go into basically what were your first initial signs and symptoms of having a concussion? When did that show up for you? Because I've heard so many different stories of some patients can walk it off right away and they don't feel anything until maybe, they get delayed symptoms a couple of weeks later. Some feel it right away. So when did that start for you? And when did you decide that it was time to seek help from those symptoms?
Yeah, you're 100% right. Like TBIs have such a variation in how when signs and symptoms show up. And I think I would describe my state of mind as my brain kind of being in an idling state rather than like a functioning one. And it's funny because I had like my boss had asked me like, how are you doing? How's everything? And the best way I think I could describe it to especially those who are also like healthcare providers is that, you remember when you were in school and you pulled like an all-nighter or something for an exam, and we had like such a crazy insane schedule. And so you might pull an all-nighter, and then that following day you're kind of in a daze, like you're there, you're lucid, but you're like not quite there. And I think in those situations, well, what can kind of solve that, as long as you're not in a huge sleep deficit, you just sleep it off and then you're back to kind of where you are before. But in this case, it's kind of, you can't sleep it off. It's like you wake up again and you feel sort of in that state of mind. And so I kind of started calling it just like an idling stage versus just being, very functional. And this state, interestingly, it took a couple days for it to develop. Like when you first have the trauma, adrenaline is pretty much running. You're there to basically in survival mode. And so I went home and I even took like a Zoom meeting instead of going to like get a CT
Oh my God.
because I was like, no, I have things to do. Like I'm busy. I don't have time for some kind of, for an injury. And then I even went to work the next day. And then as the day progressed, I started developing these classic concussion symptoms, like difficulty concentrating, headache, light sensitivity, just even frustration with kind of not being able to do what, I'm usually used to doing. And then when I finally accepted like what was happening in a sense of like, all right, well, I know what a concussion looks like. I know what those signs are. I've diagnosed it and I'm kind of seeing it in myself. Um, I had to take a step back and like change into like recovery mode. And it's interesting too, because like your brain is at the core, like what makes you who you are. Like so much of what we perceive our identity to be
Yeah,
is like
so
what
true.
we think our brain, what our brain can do
Mhm.
for us, whatever
Mhm.
optimal levels we operate at. And so like when it works right, you work right. And so when it doesn't perform in the way that you want it to, it can be incredibly frustrating and defeating. And so to return to that like optimal, like competitive level that, you just expect of yourself and decrease the risk of another concussion, you have to just kind of take the bench and then allow the brain to like rest and recover, which of course is easier said than done, but like,
Yeah.
at the cost of, if you don't do those things, you risk like permanent brain damage. And so I had gone to then when I like had accepted it and like decided to like be a good patient versus just powering through it, went
Yeah.
to get a CT scan and kind of started on that journey. Fortunately, the ER will run a CT scan or some kind of diagnostic imaging basically to rule out that there's no major brain bleed, that you
Mhm.
essentially are not going to code and have a major
Mhm.
issue. The thing is that there's so many other facets and nuances to that, and I think sometimes there's a miscommunication even then in saying that like even despite the fact that you don't have a major brain bleed, there's still several steps to recovery that you're going to have to go through. And I think there's been times where like now I have that conversation even more in depth with patients than before having gone through it myself, because
Mhm.
the CT scan was clear, but that doesn't mean that there wasn't damage. Like we think of the brain as like this rubbery fixed thing within the skull. You think of those brain models that we had like in lab where, there's some
Yeah.
pliability to it, but overall it's pretty sturdy. But it isn't. It's like it's soft and the consistency is more closer to butter or custard or maybe soft tofu or something like that. Um, and like it floats in like the cerebral spinal fluid and is housed in like a hard skull with facets that are sharp and bony.
Yeah.
And so whiplash or jarring motions, which is like what I had, those blows like to the head, it can cause the brain to slam into those
Mhm.
hard interior ridges of
Mhm.
the skull. And so then this
Yeah.
leads to internal bruising, broken blood vessels, bleeding, increased pressure, lack of oxygen, damage to
Yeah.
nerve cell connections, and like spilling out of those tau proteins. Um, and that causes inflammatory reactions. So even though there's not major brain bleeds that's showing up on the CT scan, a lot of these things are still happening on like a molecular level that doesn't really get picked up on those diagnostic
Mhm.
scans.
Yeah.
And then interestingly too, which as I was doing more reading and kind of talking to other professionals and whatnot, because your pituitary gland sits in that sella turcica, it's like a very vulnerable part of the brain. And just due to like the trajectory of G forces from like whiplash or concussive motions, it can actually cause like significant hormonal imbalances. And
Yes.
that's something that
100%.
um, I think we may discuss, but then seeing that on like a patient level too, and having that be a part of the conversation is something that wasn't really impressed upon me until I kind of was going through a lot of this research and for myself and all of that.
I think what you just said was such a big point, that there's a huge misconception with,
Mhm.
if the CT scan or the MRIs are clear, there's no physical injury, you should be fine. And that
Mhm.
is what most of my TBI patients are told, at the hospital, from the emergency room, from the MDs. And then they go home and they feel lost. They feel helpless because they think, well, okay, there's no physical injury with me. These symptoms left over is just what I'm left over with, what I'm going to deal with for the rest of my life. And you think about, neurologists know, and anyone who studies neurology, I think Deepon also studied neurology too in
Mhm.
undergraduate and graduate studies.
Mhm.
There's so many cognitive skills that the brain has. You're not seeing those neural connections physically, but they're there. And so, why would the brain not be struggling with other cognitive skills just because it's not bruised? You can still hurt without showing it. And patients need to know that so that they can advocate for themselves when, that initial hospital visit shows no damage.
And I love also how you compared the symptoms of your concussion to pulling an all-nighter, because I feel
Yeah.
like we all know what that feels like.
Yep.
And for people who've never experienced a concussion, I have never. So I never really know what someone's truly going through when they come to me and talk to me about these things. But just, I remember pulling all-nighters in optometry school.
Yeah.
And yes, I was the next day, I was always in a lucid state going like, I don't know what's going on. Who just
Yeah.
said what to me? What did I just eat? I need to go to bed and like sleep this off. But feeling that all the time,
Yeah.
oh my gosh, would be rough. Like that is awful for sure.
100%.
Yeah,
Mhm.
exactly. You hit the nail right on the head, Deepan, because you're physically present, but like
Mhm.
mentally, you, as much as you're trying to climb into a space where
Yeah.
you can be, like
Yeah.
you can't. It's like you're kind of hearing words, but it's like there's a slow processing to that.
Mhm.
And you can imagine like how fast everybody would be speaking or something in clinic. And if you have just pulled an all-nighter, it's kind of like I cannot process what is happening right now.
Yeah.
Yeah. Diana, can you talk about the different treatments and therapies you have tried and what you felt like helped the most
Mhm.
and what you felt like helped the least?
Yes, definitely. Unfortunately, I think it's very challenging for patients to find someone who will be able to kind of direct that care, especially in the initial stages, because you expect, you go to the ER, you might go to radiology, you get your test, but there isn't kind of someone doing directing your care in this
Mhm.
in that way, or at least the access to that is more challenging. Um, because a lot of the initial symptoms, they don't show up immediately. Sometimes people are just not written off, but like just think, oh, I'm fine because it's been a couple days and things should be
Yeah.
okay. Um, but what's interesting to me, and as I was doing research, it was what happens to the brain after the initial damage occurs, because there's just such a cascade of like inflammatory chemicals called, cytokines that
Mhm.
produces these excitatory neurotransmitters and an imbalance of amino acids like in our system. So like the side effects from all of that is going to be cerebral edema, which also may or may not show up on your CT scan, like depending on when you get it or even how severe it is.
Yeah.
Like a lack of nutrition to the brain cells, inflammation and decreased blood supply. And these same mechanisms like of damage, they occur whether your TBI incident was mild or severe. It's really common, and there's like research that backs, so it's really common for the brain to be working overtime and rebalancing itself at a time when it's like very vulnerable. And so because
Mhm.
it's working overtime, people can have that incidence of like a second head injury just from falling or tripping or something like that. And that is even in some cases even worse than like the initial
Yeah.
impact, because you have an already damaged brain. Kind of like if you have a sprained ankle and then you sprain it again, that's like even
Yeah.
worse than
It's
the
worse.
original sprain. And so yeah, given kind of starting to understand those things and seeing that, okay, it's more serious and this isn't something that we want to only sleep off. There's more care to do. I started actually seeing an endocrinologist and a specialized dietitian, and this was, interestingly, this is again how I like have started to advocate for my patients as well,
Mhm.
because with all of those inflammatory mediators and markers that are kind of like now in your body, it's very helpful to order panels and utilize biomarkers for a more specific treatment plan, or just kind of again assessing something and giving more name and substance besides just saying, oh, it's mild or a severe TBI. Like
Yeah.
what does that mean? We can actually utilize biomarkers to our advantage in that sense. So now I actually work and refer a lot of my patients to endocrinology, and again a subspecialized dietitian that I have built a relationship with, and will get patients started on ordering things like a lipid panel, specifically because total cholesterol will indicate like your brain health to a degree.
Mhm.
A metabolic panel to measure liver and kidney function, specifically things even like high sensitivity CRP
Mhm.
that acts as an inflammatory marker. I mean, we know that from other things
Yep.
that we've treated in the eye, that in and of itself can tell us the inflammation levels in your body. Homocysteine, which is also a cardiovascular risk factor and indirectly measures B vitamin status, which is necessary,
Mhm.
which, is necessary for brain healing and function. And then CBC with special attention to like white blood cells and mean cell volume to assess like the nutrients and tease out really what is a true deficiency
Mm-hmm.
versus a suboptimal level of like a nutrient. Um, and that will kind of tell you, okay, what needs to be raised to an optimal level to facilitate better healing of the brain. And then which ones are, or lower levels of certain ones can actually cause like neurological symptoms, such as like that fatigue or anxiety or depression that's associated with post-concussion syndrome. And sometimes these biomarkers and these panels help us tease out, okay, which one is actually from more, again, hormonal imbalances and things like that versus, possible neurologic imbalance due to just damage to a certain part of the brain.
Wow. I also knew that sending patients to a nutritionist or dietitian was helpful for TBI recovery just to reduce inflammation, but I did not know to this detail as to
Yeah.
how they could help. So that
Hmm.
was amazing, Diana. I love that. I'm definitely going to take that away from today
Hmm.
and add that in my TBI BV reports. So asking for that blood work with all those markers. Where did you learn that from? Did your dietitian share that information with you, your endo, or was that just the research that you did once you became the patient?
Hmm.
A little bit of both. I do
Yeah.
have a background in human nutrition physiology, and so I think that
Oh,
helps
awesome.
springboard. Yeah, kind of like, I know whenever I talk to Deepan, she always is so much into the research and will even pull out statistical terms that like feel like they're coming out of that research background of hers. And so I think in some ways it kind of does prime you to just want to kind of dig in a little bit deeper, just feel more comfortable with like trying to do some of digging into that research. But I really feel like being a patient completely changes like how you
Mhm.
understand a condition, or
100%.
of course you're 100% personally invested in it, but
Mhm.
truly I think it really changes your approach. And so from my background, and then being, I guess, a little bit more dogged about wanting answers and wanting to heal and all of that,
Mhm.
and then we're talking with our counterparts in
Mhm.
endo and nutrition and all of that.
Yeah. Dana, can you talk more about the prism or the microprism treatments
Oh
as
yeah,
well?
that's yeah, so this is just, it's so interesting because one, I think as optometrists, we will talk about things like binocular vision deviations and
Mhm.
disorders. And we know from literature how concussions and TBIs will affect, the binocular vision status.
Yeah.
I think what is an interesting facet that I would add from my own experience has been that because there's actually like a limited range of motion in your neck, in your body during the time that you're injured, that actually goes into how you should consider how much prism and how much prism you're using therapeutically for that. And it's, we know that it's not a static thing, it is going to be dynamic, but it just kind of reinforces how allied you should be working with physical therapy and,
Mhm.
your other counterpart, your other, allied health professionals, because that can kind of change the visual status too. So I had, asked one of my good friends who's a local OD who is, he specializes in binocular vision. It's really funny because I even had that moment, and I think probably all people that are like optometrists or doctors, you're kind of like, I could just do it myself, or I'll prescribe it to myself.
Yeah.
I think I even went through a moment where I was like, no, actually, I'm gonna have someone
Yeah.
else kind of evaluate and do it on myself. And so yeah, it's actually Dr. John Ouyang. He has a practice and he specializes in that kind of care. And so he did that and had prescribed to me some microprisms in my glasses, which phenomenally kind of helped with recovery and was able, you know, just addressing a lot of those issues with
Mhm.
just the eyes not working in a more synchronous fashion, just because the brain itself is still recovering. The
Yeah.
other aspect that I found really helpful was I saw another friend who is a neurooptometrist, and it's Dr. Jacqueline Dorr, and we basically did eye tracking tests to measure the horizontal and vertical saccades as a proxy for like neural deficits,
Mhm.
so specifically associated for TBIs. And so the results of that test kind of offered like more objective, reliable, and quantifiable data to
Mhm.
differentiate, what might just be a long-standing brain ocular disorder versus
Yeah.
one that is resultant from a TBI. Yeah, what are your guys' experience utilizing microprism and all of that for your patients? What
So
have you
what's
seen?
considered microprism? Like under one? Like base out, base in, or
Like, yeah, I mean, I think most commonly people will prescribe 0.5 to a
ah,
1,
okay.
maybe a 2. And then
Okay.
it seems like 3 and up is considered normal prism at that point. So the purpose of microprism now, a lot of students listen to us and probably a lot of new grad ODs. I think mainly when you learn about prism correction in school, it's more about, somewhat larger amounts of prism to correct strabismus or to correct an eye turn or to eliminate double vision. So usually those numbers are a little bit larger so that the eye can actually appreciate a shift in the image. When it comes to microprism, what you're doing is you're altering someone's perception of the space around them. So you're not trying to necessarily shift, your world up, down, side to side, in or out. But when the brain gets so toggled around from a head injury, it really messes up either your peripheral processing or your central processing, right? So those are kind of two separate functions, all depending on if you're stuck in that sympathetic nervous system or parasympathetic after your head injury, right? When you're in the sympathetic mode, you're more into your central vision only, because you're really just like, okay, I need to run away from this bear. I need to know what's in front of me and I just need to go. When you're more calm, relaxed, you're in your parasympathetic state, you can appreciate more of your periphery. You're more relaxed. You can appreciate your surroundings. So microprism allows the brain to process a little bit more of your peripheral space or your central space. Like Diana mentioned, I don't think Diana has mentioned it yet, but I think you did kind of brush over. You did a little bit of PT as well. So with physical injuries, right? Your body may not be able to, walk straight. You might be putting more pressure on one side of your body more than the other. So you're appreciating more of the right side of your vision versus the left. So we can use small amounts of prism to just alter the way you perceive the space around you, so that you're processing a little bit more and comfortably. So it's not necessarily getting rid of double vision or, an esotropia. It's just the way that your brain processes all that visual information coming at you. That's how I'm understanding it so far, Diana. So even for me, I've just learned these concepts like within the last year. And it's been great for my patients, but I'm still kind of like learning and experimenting at the same time. So that's why I was really interested in hearing kind of your personal experience with it too.
So how's it
Yeah,
working for you then, Diana? Because you were prescribed microprism, correct? Yeah. So how has it affected you so far?
it's really been, I think, for the right patient, and of course that's where it comes in of the proper patient where this is indicated for. It really has made a phenomenal difference. I think
Mhm.
I loved Amrit's just like explanation of it, because it really is true. That's sort of, there's so many markers that we use in our physical body to orient us in space. It's pretty amazing. Like even how we stand or prefer one side of our body versus the other, and all of those feedback loops tell us where we exist in space. And so when you're having basically your brain like jostled or mixed up, there is a period of time where it itself has to kind of reorient itself. And so if you can, again, I would think of it kind of like you're wearing a brace or using a crutch during a time where you've like injured your ankle. It's kind of there to just give support to your brain in order to,
Mhm.
as it heals, it kind of has some of these things in place and guardrails. And so really, I would notice that there would be a marked difference using that when I would be at work or had returned to work and done all of those things, a difference in like fatigue levels and all of that. And I
Mhm.
think that that's where the value really comes from it. It's harder, and Amber, you might have noticed this too, but sometimes it's harder to like quantify some of those things
Oh
because we
yeah.
are working at like a microprism level. And
Yeah.
the Phoropter itself has units that are kind of limited in that way. But that in and of itself if you're opening up someone's peripheral field when they are locked into sympathetic overdrive or something, that's going to be a huge difference in helping them as they recover. And that may not be something that one needs forever, but again, you utilize the resources that you have when you're recovering, because there's no shame in like using that to recover. Yeah, I've like worked with a couple patients now and had utilized some of the microprisms to help. And most of the time there is an aspect of that conversation where patients will be like, well, I don't want to be dependent on this. And it's like, actually shift your frame of mind, shift your perspective on that, because it's not being dependent. It's there to help you as you recover.
Yeah. And it gradually tapers down depending on the patient, depending on the recovery process. You're not expected to use the prism, not even full time for the day. You know, we might even recommend when you're at work, put on your prism glasses, and when you're at home, take them off. And then as you do the follow-ups, as you recover, you start to taper down and try to take out as much of that prism as you can until the patient has reached a goal that they're trying to achieve with their recovery. So yeah, it's pretty cool. I'm glad that you tried it, and I'm glad that it's helped.
I just had another
Yes.
question about it. When you guys
No more.
or when it's this might be a dumb question actually, because I'm just thinking if
No.
you try to prescribe something like that, are you like trial frame or like how do you even know, or is that something you just know from like the literature, like 0.5 base in prism or something like that? Like how do you know what to give the patient if it's that small of an amount?
Well, I would definitely utilize loose prisms.
Okay.
Yeah, of the patients that I've now incorporated that with, it's been loose prisms that you know, even at those levels, you know, not every patient case is the same, but I do think having that personal aspect to experience just does help add some nuance and color to how you're listening to the patient and hearing the patient. And so, or yeah, utilizing some of the loose prisms and then seeing, one, watching just objectively how their eyes are moving, and then two, observing kind of how they walk and how they,
Yeah.
Okay.
hard to use this phrase, but just honestly how they feel, again, orienting themselves in space, and just like how aware they are of their surroundings and even their body, depending on how severe their trauma was.
I think you're saying it perfectly, because it is hard to explain. I mean, if anyone out there is interested in learning how to prescribe microprism, because yes, you can totally do it in a primary care setting, but you do have to understand how to prescribe them and when and for who. Because like Diana mentioned, it's not for everyone, and you don't even know what base direction to prescribe. So you look at their balance, their posture, the way they stand, the way they walk. You want to take into consideration their binocular and accommodative system. Are they esophoric, exophoric, orthophoric? Are they accommodative excess, insufficiency? Check their pupils. So do they have this alpha omega pupil when they're, responding to bright lights? And then, you get a general sense of, like I mentioned, you're processing vision differently when you're in a sympathetic mode versus parasympathetic. So you need to evaluate their mental health status. Are they more on the anxious, turned on side where they're always, over functioning? Or are they very low, very depressed? They have a lot of fatigue. And actually, at the Bolton Optometry Clinic, we do have a space board, which I've just learned about it too, and I'm still learning, where you set the patient up with a board where they actually, with a pen and paper, can map out how they perceive space. I'm going to be very loose with this explanation because I don't know 100% about it, but you have to draw out a rectangle for each eye. If that rectangle is slanted or expanded or crooked, you can literally just look at that board and see what they visualize in their world. Is it a rectangle, or is it a trapezoid? Is it a diamond? And then that actually can help you quantify what they're perceiving in their space. And that can give you a very direct answer of what base microprism they benefit from to straighten out their space and match that rectangle a little bit more. So there's a lot of cool stuff out there, but you got to dive into the BV world if you really want to do that and help your patients. Anyone who wants to like really get into that, look up COVD, OEPF, VTC, like, all those organizations that deal with vision therapy, you'll learn a lot from those resources. Yeah.
To jump off what you're saying about really taking into account that parasympathetic and sympathetic
Yeah.
activation aspect to that, most people who have been in any kind of traumatic incident are in that fight or flight sympathetic response, whether they think that like they're not, or they are kind of calm and zen and chill in the moment. It doesn't change like physiologically what the body like perceives it's in. And it was just assaulted essentially. And so
Yeah.
there is this component of you go into survival mode. And so it does certain things in order to help you survive, but it doesn't know when to kind of shut that off. And if the brain is continuing to have to heal and all of that, it's not gonna get those cues to shut off for a while unless there's some external things to kind of help iron out some of that.
Yeah. Let's wrap up that, based on the treatments and the therapies that you just talked about. I just wanted to add one final question to that so you can kind of wrap that up for the listeners. What healthcare professionals were you referred to for the management of your concussion, and what healthcare professionals do you recommend for concussion patients to seek out? So I guess that ultimate roadmap, who else would you recommend based on what you've already mentioned?
Yeah, that's a great question. And I think I would love it if optometrists kind of start adding this to the way that they do referrals for TBI patients. It's certainly, again, like I said, it's completely shifted how I manage some of my patients. One thing that I think is really important to add here is the role of a physical therapist in the recovery here. And there's, just like optometry, there's subspecialties to physical therapy too. And I would be looking for partner with providers that do specialize in concussion, TBI, and all of those things. Because I think traditional therapy, physical therapy, they focus on muscles, tendons, bones, ligaments,
Yeah.
and the like. And so that is absolutely necessary. There is a subspecialty called strain counter strain physical therapy, which actually looks at the whole body, including the lymphatic system, the nerves, fascia, like organs, muscles, and even like the arteries and veins. And so, like we were talking about, when you're locked into that sympathetic mode, there is more there's more at stake, there's more at play here, because something, it extends to the entire systemic aspect of the body. So until I had my issue, I had not actually heard of strain counter strain before. Have you heard of it before?
No.
Yeah, so it's really fascinating to kind of dive into that world. It's essentially soft tissue manipulation. It's developed by ortho. And basically, from kind of how I've understood it and from talking with my providers, and it's a normal functioning lymphatic pump mechanism, and like venous drainage is necessary to remove inflammatory mediators. And like we've been talking about, there's just so much inflammation in the body during stress, and especially during a TBI. If there's inflammation in those spaces, that is what creates like continuous pain and neuroinflammation. And so there's not really a way for some of those pumps and those drains to like really release the flood of inflammation that exists there without some manual manipulation, actually, to kind of jumpstart things and get things healed faster. I mean, the physical therapist will actually work to just improve that vascular function again through mechanical manipulation, and then kind of stop that feed forward loop that's happening, that's causing that chronic pain. And so I kind of wanted to touch on that because, again, with TBI, there's also it spreads out into like the whiplash and the neck pain or back pain. You can have that inflammation that builds up even like iliosacrally and all of that, even if you think you've just bumped your head, there's kind of further down the line impacts on the rest of your system.
So, Diana, do you feel like yourself again, or do you feel like there still needs to be some time before you get to yourself again?
I like how you raised that question too.
Like basically, do you still feel like a zombie, or
do I still feel
like
actually, if I digress for a second, if I were to create like a meme of like that optometry school, that time where we were just pulling a lot of all-nighters, it would be like, how much coffee do you want in your, like how many espresso shots do you want in your coffee? And then it would be like third-year OD student. I'd like it to show up on a drug test or something. Like that was
Yeah.
the extent of like how active people might be during those times. And yeah, I certainly am not in that period at anymore, which is wonderful
Right.
because it's hard to be in kind of that, yeah, that kind of headspace. And overall, you know what, I think there will always be things that I think it changes kind of how you think of your health and how preventative and proactive you are about different things. Like in some ways, it's kind of like I have a very good relationship with my physical therapist now, and it's kind of like, oh, I understand sort of just the body mechanics and how I would want to move forward in kind of making sure that everything stays really healthy. And so I don't actually think I'm like the same anymore because it's completely changed like the perspective in a good way, in a way that changes like who I am, but also like the advocate I can be for these types of cases and also my patients. So overall, you know, at this point, yes, there's a light at the end of the tunnel for those who are suffering from TBI, though I do again want to preface with the severity of different head injuries, that journey can look really differently. And I do want to honor the fact that some people really do have a road to recovery that is very extensive and labor intensive too. But at the end of the day, and this is something that a colleague actually told me when I was like in the throes of like recovery and just like very frustrated, that the brain is really resilient and it's there to kind of help you survive and it wants you to thrive too. And so it heals, it's neuroplastic like we know. And so there is there's a lot of hope for people, and especially with emerging technology. And again, what I was describing with the use of panels and biomarkers and finding that health and healing. And so so to answer your question, Deepan, yes, I'm feeling much better, thank you. And and it's kind of changed you know, how I operate and live in this world moving forward.
Well, we're so happy to hear that. Honestly, it was so nice to hear your story when we connected at Mod Live 2023. And we're just so happy that, you know, based on the trauma that you experienced and, you know, when you told us, we were so happy to just see you thriving at the conference and just having fun and just still just putting yourself out there. And what you just mentioned was excellent advice for anyone who's suffered a concussion. The brain is resilient. It will heal, but like everything in life, it just needs time. Do you have any other last minute advice, Diana, for new grad or primary care ODs who deal with concussion patients in their chair?
Case history is so integral. That's, I think, a clinical pearl that I've kind of walked away from this whole experience, is that a good case history is going to kind of tell you so much information about the patient, especially in these TBI types of situations. Again, it's that first point of the exam, and sometimes it can get glossed over, or we just have different agendas on how we want to run our exam. But that's something that will kind of really add twofold to the type of care that you can give your patients.
Yeah. Awesome. Thank you so much, Diana, for coming on and sharing your story. We loved it. And I really hope that it resonates with a lot of the listeners, whether they've experienced a head injury or if they're just seeing patients on a regular basis with head injury. So we wish you the best in the rest of your journey to recovery. And we look forward to seeing you in person at some of the next conferences coming up. So yeah, thank you again.
Thank you for having me. It's such a pleasure.
Thanks everyone for listening to Four Eyes, the podcast series brought to you by Young OD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. We'll see you next time. Bye.